This video will cover the common injuries of the wrist and hand. Most of the wrist injuries that you will see will occur either from some kind of trauma like a Fuchs type of injury or from a repetitive stress injury, flexion, extension, rotation, and that can be a sport or work-related cause. We'll start with a wrist sprain, by far the most common wrist injury, and we really don't do the best job at managing it, whether it be in sports or in work-related injuries. This can happen from, a fall, any kind of abnormal movement that's happening. But again, that Fuchs injury is the most common cause of this. Because there's so many ligaments in the wrist, like we went over, it's just bound to happen if you have any kind of trauma that you're going to have damage to some of those ligaments. So the signs and symptoms, generally the person will tell you it's painful. I think the biggest one is losing motion in the wrist. So usually the time they do it, not so bad, not so bad. But once the swelling sets in, it's really hard for them to do normal movements of the wrist. So that's when checking them, doing normal things like buttoning or tying their shoelaces or whatever would be a good way to evaluate this person. Treatment-wise, obviously you want to get them out of pain first. Here's where we struggle. A lot of people just think, oh, the pain's gone, so I'm fine, and we don't do the strengthening that needs to be done. So that's where therapists need to step in and really say, look, we need to re-strengthen and regain the normal amount of motion and tension in those muscles so that they're not going to get that same injury again. Because what happens with, I would say, most sprains in the body is that we just don't take care of them and strengthen them like we should. You can also do immobilization, taping, that kind of thing. If there's a severe trauma, you always want to co-manage with the physician. We just want to make sure there's no fractures involved. They can be very occult in the hand, very hidden, and it's better to be safe than sorry. It's not a lot of radiation to do wrist x-rays, so if you even have any kind of idea that maybe something's going on, go ahead and co-manage that. Okay, triangular fibrocartilage I talked about in the evaluation section. It's just a little piece of cartilage. But if you have some kind of forced hyperextension of the wrist, that can cause a lot of compression of that cartilage, especially if you've got any kind of hyperextension with a radial deviation or a rotation to that side. It just tags on that cartilage and can tear it. So it's usually, there can be a UCL injury along with it, but if they've got a severe hyperextension and point pain right over that TFCC, it's a pretty good bet that that's what's going on. The person literally can point right to the ulnar side of the wrist and say it hurts right here. They can't extend their wrist. There can be swelling or there can be no swelling, so it's tricky in that way. But basically, if you have any idea that this is going on, they've got to get an MRI. That's number one to rule it in or out, whether it's torn. And then we really need to manage it appropriately, because if we don't, they can end up with a permanent disability and loss of motion in that wrist. So that's kind of one that needs to be referred out. Tendonitis, really common in sports as well as in work. Anything where you're doing a lot of excessive gripping like you would in a racket sport or even in cycling, the tendons just get tired. It's long-term exposure. It's overuse. Overuse is the most common cause of tendonitis in the wrist. So you can really get it in any of the muscles we discussed. They're going to have pain when you use the muscles, and they're going to have pain when you stretch the muscles. So whenever you've got a tendonitis, that's the best way to try and isolate what's going on. Have them use it, have them point the pain out to you, and then try and resist it so you can isolate the muscle. The treatment, obviously, you got to get them out of pain first. That's always number one. Wrist splinting is very important in this, just so the tendons get a break. And once you've got the swelling gone, then you can start your exercises. Then you can start doing some resistance training and whatnot. But you really need to get them out of pain and get the tendon healed and a little more stabilized before you start doing that kind of thing. All right, this is a little bit of a tricky one. It's interesting for sure. There's a lot of nerves in the hand, and they have to go through these little teeny tunnels. And so there are places where we can get nerve entrapments. The most common ones, obviously carpal tunnel would be one, and that's the median nerve. The ulnar nerve goes through this little tunnel called the tunnel of Guyon, and it's teeny, and it's by the pisiform and the hook of the hamate. So it's just a little guy there. But if you have injuries to these nerves, all of a sudden you end up with these strange hand placements because of that nerve compression. So I'm going to show you some pictures in a second. But it's obviously very painful, sharp and burning pain. Their skin feels like pins and needles all the time. So if they end up, there's a couple of different deformities that can happen because of these. A really common one is called the benediction deformity. So if you're familiar with the Catholic Church at all, when the bishops bless people, they usually lower their fourth and fifth finger and hold up their second and third finger. So that's what would actually happen because that ulnar nerve is not working. So we call that a benediction deformity. If they have a compression of the median nerve, they can have median and ulnar nerve, then they can end up with what's called a claw hand. I've got pictures, so hang on a sec. If you have a problem with the radial nerve, you can actually end up what's called a drop wrist. So the radial nerve's on the posterior side, and it would cause extensor muscles to be paralyzed, so you can't extend your wrist or fingers. And then the median nerve by itself can cause what we call ape hand, where the thumb is pulled backwards, sort of in an extended position. So let me show you what these look like. So here, this is your benediction deformity. Just like I described, these fingers, because the ulnar nerve is here, are stuck down. If you have the median nerve and the ulnar nerve, okay, then you get claw hand, which means all the fingers are stuck down like that. If you have a radial nerve injury, you're just going to have a drop wrist, can't extend those fingers, can't extend the wrist. And if you have what we call ape hand, that's going to be a median nerve compression. Definitely these three fingers and the thumb pulled back. Sometimes the pinky's involved as well. So I would just kind of know, okay, this is the ulnar nerve, this is ulnar and median, this is radial. How do we treat it? We don't. We send it out to someone else so that they can surgically decompress, and then we can support them post-surgically by strengthening some of the muscles, making sure they have good range of motion, that kind of thing. All right, carpal tunnel. This is kind of the big injury of the wrist that everyone talks about, right? So the floor of the carpal tunnel is going to be those carpal bones, and the roof is the transverse carpal ligament and that flexor retinaculum. So there, like I said earlier, are 8 finger flexors that go through that tunnel. They have sheaths, that's their coat that goes around each tendon. And we've got the median nerve going through there. So if there's any kind of tendonitis, any kind of inflammation, that nerve is getting compressed because the tendons are a thicker substance than the nerve. So the nerve loses out, the nerve gets compressed. And this is going to be people that do repeated wrist flexion. It can be caused by direct trauma, but you really don't see that as much. So what's the person going to say? Well, they're going to say they have a lot of pain, tingling, and numbness in their thumb, index, middle finger, palm of the hand. They just feel like their hand's weak, it aches, it just doesn't feel right. So obviously we want to make sure we have an accurate diagnosis. We can do nerve conduction studies, MRI, that kind of thing. And initially we want to immobilize them to try and get rid of the inflammation. NSAIDs can be used, injections can be used. There's a lot of different options, but a lot of times what they have to do is just go cut that ligament, and it's just called a carpal tunnel release, and maybe some of you know someone who's had that. That tends to be pretty effective. They cut the ligament and then it scars back, but it scars back looser, so there's more room in the tunnel. But this is a very difficult and common injury that we see very, very often. Daycare vein syndrome, I mentioned when we did the Finkelstein test. This is basically every tendon has a lining around it, right? It has the sheath that's around it. If you get a stenosis or a narrowing of that tendon sheath relationship, you can get a lot of inflammation and pain throughout the tendon. This can happen in the biceps as well, but very common in that thumb. And what's funny is now that people are texting so much with their thumbs on their phone, this injury actually has become more common than it used to be because of the excessive thumb movement that we're doing now. So the tendon has to kind of slide back and forth through a groove, and when you're constantly moving that thumb and wrist, you can get irritation, which would cause this syndrome. They're pretty much going to say that they have pain right over the wrist and right over the thumb. So Finkelstein's is your way to diagnose it. Point tenderness for sure. If they can't do thumb extension or there's any kind of catching, those are all good signs that something is going wrong. So management wise, we got to mobilize it. Rest, so important. Ice, NSAIDs, ultrasound, all that kind of stuff. It's mostly just about stopping them from overusing it so much. Okay, lunate. This is going to kind of throw you off a little bit because it's a little different than what I told you earlier, but there are some different schools of thought on how the lunate gets dislocated, what causes it, etc. Point being, it's an extremely painful injury. It's caused by some kind of traumatic stress on the wrist, whether it be a foosh or whether it be a fall on a flex wrist. To me, doesn't really matter. If it gets dislocated, it gets dislocated, okay? If it goes anteriorly, which is quite common, now you're talking about some injury to the median nerve, right? Because it's going to push into that carpal tunnel. If it goes posteriorly, painful, but not really going to be as much of an issue. So you got to kind of think about that. It's not even a right or wrong thing. It's just how did they injure it? So obviously they're going to have a ton of pain because dislocations are extremely painful. Swelling, can't do their normal movements. They can have paralysis depending on if that median nerve is involved or not. And just not being able to use their wrist like they should. You're going to treat this like you would any dislocation, which is send them to a doctor so they can fix it. But sometimes this can be one of those, maybe somebody missed it and they walk into your PT clinic and you're evaluating them. So check for these things because you never know. Even if it's a partial dislocation, it can cause long-term problems. So always check for it. And if you're not sure, MRI, X-ray kind of things, because you can end up with deterioration of the bone. And that's a whole nother can of worms that you got to deal with. So just always be thorough in checking every bone in the wrist and making sure it's where it should be. So here's a picture, okay? It's going to be sliding forward, so you can see it's right into that carpal tunnel, and that can cause a lot of pain. Scaphoid fracture, very, very, very common and very, very commonly missed injury. A foosh is going to be your most common cause, okay? Just falling on that hand. A lot of times doctors will say, oh, it's just sprain, no problem. Here's a wrist brace, you'll be fine. But the problem is that the scaphoid has a very sensitive, it has a sensitive blood flow. So if you really break it in half, usually a smaller piece will break off, and that smaller piece will fail to have the blood supply that it needs and eventually can cause avascular necrosis, which if you remember in the hip, it just means that the bone basically breaks down on itself and disappears. Now you think, well, whatever, it's not a big deal. Do you need it? But you do, because there's so much interaction going on in the wrist. If you don't have that scaphoid the way it should be, it's going to affect your movement. So anytime somebody sprains their wrist, again, if you have any inkling that there might be a fracture, better to be safe than sorry, co-manage with a surgeon or just a doctor at least to get x-rays. Okay, and if they have pain right in that anatomical snuff box, point tender, pain right there, it's pretty obvious that they've at least injured that bone, if not broken it. So swelling, point tenderness there is what's going to cause some concern. Obviously, you want to ice it, send them for x-rays. They're probably going to be in a cast. I have seen people being cast for months with this because it notoriously heals slowly. So if somebody has this, be sure to let them know to be patient because you want it to heal appropriately, but sometimes it takes a while. I don't know if you can see it real well, but there's a fracture right there in the scaphoid. But you could see how somebody would miss that, like, oh yeah, it's fine. But it's really not an issue. You can actually see the ulnar styloid process really well on this. And just since we've got the picture here, this is where the triangular fibrocartilage lives, in this little spot right here. So anyway, that's a scaphoid fracture. Wrist ganglion, these are kind of weird. They happen at times. They're just little cysts in the wrist, and it's basically the joint capsule herniates into the tendon. They don't really know why it happens, but it gets full of fluid, and you see these sort of lumps on people's hands, okay? It's usually on the back of the wrist, but it can be anywhere in the wrist. So this is just a drawing, and sometimes they're not that big, but They're going to have obviously pain and this lump that came out of nowhere. So that's usually a good sign that they've got a ganglion going on. So how do we fix it? Well, in the olden days, they used to take a large book, usually the Bible, and just smack the heck out of that thing and break the cyst, and then it would reabsorb into the body and they'd be good to go. I can imagine that that was rather painful. So what they do now is usually we'll stick a needle into it and either try to cauterize it with chemicals or aspirate the fluid that's in there. The important thing is that you put a pressure pad on it over time afterwards so that it can't refill with fluid. But the problem with ganglions really is that they just come back a lot. So yes, they're annoying and they're a little bit painful, not detrimental or life-threatening in any way. They're just annoying. So sometimes people will elect to have surgery to sort of try to correct whatever's causing it. But it's just kind of one of those strange things that happens in the wrist. All right, now let's move to the hand. The hand is notoriously unforgiving. What I mean by that is you injure your hand, you are going to feel it forever. It doesn't forget when it gets injured. There's not much protecting the hand. There's not a lot of muscles, in the fingers and whatnot. So it's really a lot of bones that are just open for injury. So contusion injury, pressure injuries, real common. Smash your hand in the car door, whatever, any kind of bruise that's going on. And usually the person will have a pretty specific history, like, hey, yeah, I slammed my hand in the oven or whatever, so that they can identify where the pain came from. Treatment-wise, all you can really do is put ice on it. There's not a rehab type of thing that you would need with this. It's going to be sore for a while. They may want you to create some kind of a protective padding or a hard shell pad for them, depending on what their normal daily activities are. But it's just one of those, it'll get better, just put some ice on it kind of injuries. And one of the things that can happen, especially if you have a pressure injury of the finger, and some of you may have experienced this, is you can get what's called a subungual hematoma, which is blood under your fingernail. Super painful because of the pressure that creates. So if someone has this and it's fairly new, what you can do is put it in ice right away, ice water, to try and get the blood vessels to shut down. And then what you do is, this sounds really weird, but you take a little tiny drill and you drill a hole in the fingernail and the blood will come out. And people think, oh my gosh, doesn't that hurt? No, it doesn't hurt when you cut your fingernail. So it wouldn't obviously hurt if you drill your fingernail, but it seems strange. So there's little drills that they make for this specific thing, but that's usually the best way to get rid of it. But if it's been there for a while, there's no point in me drilling a hole in the finger because the blood's already dried and it's not going to come out. So you try to catch this early on, and it's just really to relieve the pain. It doesn't matter if you leave it in there or take it out. It's more comfort of the patient. Okay, there's going to be a few kind of strange injuries in here that you may or may not see at any point. Trigger finger. It does happen. It's an inflammation in the tendon sheath. Usually extensor tendons are going to have this issue, and it's another stenosing tenosynovitis, just like Descartes. And it's usually going to be in a flexor tendon, especially if it shares a sheath with any other tendons. It's really just overuse, and their finger pretty much gets stuck. So their first finger looks like they're pulling a trigger. It's kind of flexed in and they cannot extend it because of the inflammation in the tendon. So they'll pretty much come in and say, hey, so I can't extend my finger. That's weird, right? And it may have a snapping noise. It may be really tender. You may feel a lump. But the treatment, again, is the same. You've got to rest that area and let the inflammation go down. You may have to do a steroid injection for this type of injury, or use steroid cream, or splint it. So it's just, again, one of those kind of weird things that happens to some people with overuse. Okay? All right. You'll see a lot of this finger, that finger, whatever. So try and differentiate between them what they are. Mallet finger. This is think about a basketball, right? You're playing basketball. Somebody passes you the ball. It hits off your middle finger. Okay? If it jams the finger, part of the extensor tendon rips off. Now all of a sudden their dip or their distal part of their finger can't extend anymore. So it's kind of hanging down. Okay, that's what mallet finger is. It looks like this. And it's because you've torn that little extensor digitorum profundus, okay, that came all the way down here to flip that up. So what do? Well, we look at the x-ray, make sure they don't have any major fractures going on, okay? Sometimes you can feel that little piece of bone they ripped off. That can happen. But pretty much what you do is put them in a splint, send them on their way. There's nothing else we can do for that. It needs to heal on its own. And then you may do some rehab once it's been 6 or 8 weeks and they've regained the integrity of that muscle. Boutonniere deformity. Boutonniere means buttonhole, in case you didn't know that. And it is caused by tearing the extensor tendon of the middle phalanx. So it's a little bit different than mallet finger, and the finger's going to look different when they come in with it. So the dip joint is extended, the pip joint is flexed. It looks like this, okay? Don't really know why it's called a buttonhole deformity, but somebody decided that. So again, anybody comes in, they're in pain, they can't move their finger like they should be able to, we're going to want to do some x-rays or other diagnostics to figure out what's going on. And then we're going to put them in a splint. We're going to tell them not to use it. And then after that, or even during that time, especially in this case, because the distal phalanx is stuck in extension and there's nothing torn in that one, you're going to have them just work on flexing their distal phalanx. So I know it seems weird to say, okay, flex that finger, work on that all the time. But it's really, really important because, like I said, the hand doesn't heal well. And if we don't take care of it, it's going to be a long-term issue. Okay, I don't know how to say this word, I'll be honest. I think it's Dupuytren's. I might be wrong, so don't make fun of me. But at any rate, there's no cause for this that we're aware of. It happens to certain people. My father-in-law has this. They get all these nodules in their palmar aponeurosis here, and all of a sudden they've got this flexion deformity of either their ring finger or ring and pinky finger. So they can't extend it. It is so tight, there is nothing they can do. And it just happens to some people. What do? Usually they go in and surgically cut it, remove the nodules, put them in a splint that's going to keep their hand extended, hope it doesn't come back. For him, I want to say it's probably come back 2 or 3 times. So it's just a weird little thing that happens. But this is why it's important that we tell people to maintain, stretch their fingers out. Don't always be in a flex position because you just don't know when these kind of things could happen. Gamekeeper's thumb, this is a common injury, and it's actually a pretty bad injury. But if you imagine a gamekeeper being a goalie, okay, I'm a goalie, you shoot a ball at me, and it hits my thumb and just extends it really, really far, okay? So that's forced abduction, forced extension. That will tear the UCL of the thumb, okay? So I know there's UCLs everywhere. Yes, there's one in the wrist, there's one in the elbow, and there's one in the thumb. So if I tear that thing, it's going to make my thumb unstable, okay? So they'll have a lot of swelling in this area and pain right there, right over that joint. So if there's tenderness on the medial side of the thumb, definitely keep this in mind. Treatment-wise, if there's any instability, they're going to have surgery. There may be a fracture associated, so you want to check on that. But pretty much, you're putting them in a splint for about 3 weeks, and then after that, you can work on some thumb exercises to try and stabilize it. But this is one you don't want to miss it, because if they have instability and it stays there, they're going to have long-term issues. Okay, finger sprains happens all the time, okay? Like I said, to me, it's not really that important to isolate what specific ligament and what this and that. If they have a sprained finger, they have a sprained finger. You usually get it from some kind of jamming force, okay? But it can be a sideways force as well. They're going to have pain. They're going to have tenderness. They're going to have swelling. It's just real common to pick these out fairly easily. Treatment-wise, if you feel like you need to do an x-ray, do it. Otherwise, you're going to splint them in a finger splint, or you can buddy tape, which means you just tape it to the finger next to it. It's really just waiting it out. And there's not really a lot of muscles per se around those joints where I could say, oh yeah, well, once they're better, strengthen this muscle, because there's really not. So you just want to stabilize it, let those ligaments heal, You can use maybe some arnica or other creams or things to help promote the healing, and then just have them protect it in whatever activity they're performing. All right, dislocation. So if I have a PIP joint, right, proximal interphalangeal joint, and it's dislocated dorsally, so towards the back of my hand, this is usually seen in like a collision or contact sport, okay? It's usually because of a hyperextension. So for these, all the rest of these injuries I'm going to go over, I would just know, okay, a PIP dorsal dislocation is caused by hyperextension. That's the most important thing because it's nasty. Look at that. Okay, ooh, nobody wants that to happen. There's an obvious deformity usually. So that is like visit to the hospital and get it in a cast kind of thing, clean them up. Usually it's going to be about a 3-week journey with this one. So that's a hyperextension. Palmar dislocation will go the other way. Twist while it's in flexion. Okay, and again, everything else the same. It hurts, it looks weird because it's not in the right place. People freak out when their joints are not where they're supposed to be because your brain actually is not able to process it. So if you're ever in a position where you're around somebody that dislocates a finger, just try to get them not to look at it, cover it up with a sweatshirt, whatever, because they will go into shock from seeing their finger in a way that it's not supposed to be. Just a little side note there. Again, splinting for this one and continued protection for at least a month or 2 after that. All right, if you fracture it and dislocate it, it's usually from an axial load, which is basically jamming straight down the finger with a great deal of force. Again, anything like this where you're not sure, you think it's pretty bad, just refer out. And if somebody comes directly to you, make sure that you've had an x-ray. MCP dislocation, a little bit less common, but it's usually some kind of twisting force or a shear force, like maybe your finger gets stuck in somebody's jersey and it gets twisted and whatnot. You'll see pain. Usually this one, the times I've seen it, it's been the 5th metacarpal phalangeal joint because that one, otherwise the other one's all nicely packed together, but the 5th one's kind of hanging out by itself. So if it happens like that, that's usually the one it is. You just want to put some ice on it, splint it, make sure it gets reduced. Metacarpal fracture, this one I would definitely know, especially what we call a boxer's fracture. So a boxer's fracture means, and I've seen this a lot of times in high school, like somebody punches a wall and they break their 4th and 5th metacarpal. It just kind of happens. Or maybe they get their fingers stepped on or something like that. So that's what you want to look out for the boxer. Excuse me. So here's what it looks like on an x-ray. And you can see the fracture right there. Right in this area. It's going to hurt. It's going to be swollen. Usually their hand will be a little bit deformed. So that's what that's going to end up looking like. Generally they're going to be in a cast or splint for about a month. Okay, Bennett's fracture. Kind of similar to the gamekeeper's thumb. It's a thumb injury because their thumb got abducted too much. So again, this is I got my thumb caught in somebody's uniform or whatever. Just a weird thing that happened that pulled the thumb in an excessively abducted position. So they're going to have pain and swelling over the base of the thumb. You look on an x-ray, you'll see the fracture. And again, this is one. Anything with the thumb, you want to refer out first or co-manage with a surgeon because thumb instability is going to be a big problem for that person down the road. All right, last few fractures here. This one I've seen personally a few times. Distal phalangeal fractures, that's like your fingertip getting fractured. Almost every time this is a crushing injury. So one of the times I saw it, it was, I was in the weight room and the weights came down on my finger and crushed it. It usually looks a little bloody. Especially if there's damage to the fingernail itself. So you want to, watch out for that. But generally, if they've had a severe crushing force on the end of the finger, this is what happens. But is there a lot you can do? Not really. They don't cast it or anything. They'll just put it in a splint that the person has to wear until the pain goes away. Middle phalangeal fracture. usually just a direct trauma to that part of the finger or a twisting trauma. And again, you'll look on x-ray, make sure that the bone's not displaced, meaning it's not out of alignment in any way, because they'll want to fix that. Otherwise, it'll heal in a not straight position. And pretty much you just give them ice, pain relievers, buddy tape it or splint it, and they're good in a few weeks. But you want to keep protecting it for several months just to be sure, because bones take a long time to heal. I mean, they heal in about 4 to 6 weeks, but really it continues to reform over the next year. All right, if I have a proximal phalangeal fracture, generally it can be a spiral fracture, so it sort of goes around the bone. It's not just a clean break. They can be a little trickier to deal with. They're obviously going to have pain and swelling, deformity, that kind of thing. And again, you just give them rice, pain relievers, stabilize it, x-ray it if you need to. That's about all you can do with that. All right, we are done with the wrist and hand.